All right. So today we're going to talk about platinum-based anti-tumor agents, and I think um, these are drugs that are often we just don't really think about. But I think there's some the pharmacology of these drugs in the cancer pharmacology space is actually quite well developed, and hopefully I can touch on that today in terms of what we know about these drugs. So I'm going to talk about a little bit of mechanism, a little bit about resistance, their pharmacodynamic relationships, and then where we go on. These drugs aren't going away. They're they cured Lance Armstrong. So these are drugs that for some tumor types are amazingly effective. And the first thing to remember when we're talking about platinum drugs is they are made up of platinum, and platinum is a word and a phrase and a concept that's broad throughout our society, from platinum blonde to platinum credit cards, right, to platinum records. And I couldn't help but put up Master of Puppets by Metallica just because I was in college when that came out, and I love that album. But this is a transition metal, and it's a transition metal that has had relatively large impacts on some people's lives because of its ability to kill tumor cells. And the discovery of platinum is actually very interesting. So Barnett Rosenberg was a chemist at Michigan State University, and he was actually studying the effects of electricity and electrolysis on the growth of E. coli. And as shown from his publication in Nature in 1965, when he treated these E. coli, they stopped dividing and they grew like by 30-fold. It says they grew up to 300 times the normal length. So what it did is it blocked their division but not their growth. Dr. Rosenberg had done a series of experiments, and what he found when he was doing this, that it wasn't the electricity, it was the platinum electrode, because if he used other electrodes, it would not. And in this paper, he'd already kind of discovered that. Picture of Dr. Rosenberg up here. He quickly kind of realized that this anti-proliferative effect might be beneficial for cancer. And in 1969, they published the first kind of study here. If you look in these mice with sarcomas, are really big, and you treat them with cisplatin and they kind of go away. So this is cisplatinum, cis-dichlorodimenoplatinum. So Dr. Rosenberg, like I said, was at Michigan State. One of my good golfing partners and friends is a Michigan State alum, so I had to put a Sparty helmet up there in honor of him. And so, these drugs were discovered a little bit by serendipity and a lot by observation. And so, like I showed you in 1968, 69, they were putting it into mice. By 1971, they were starting their first trials. And it was FDA approved under the name Platinol for treating patients with metastatic testicular, ovarian, or bladder cancer in 1978. So, it was a fairly quick turnaround in discovery of this. And here in a cancer chemotherapy reports from mid 1975, it was recognized, the tumor most sensitive to cis-dichlorodimenoplatinum was testicular carcinoma, in which 7 complete responses, 3 partial responses, and 3 improvements were observed in 16 patients treated at Roswell Park. So you do the math, it's 13 of 16 patients seeing objective responses to, a tumor that wasn't responsive to other things. And so the platinum agents pretty quickly, and cisplatin itself pretty quickly became approved and became a definitive treatment for some tumors. So if we look at the platinum drugs themselves, currently in worldwide use, and the year they were FDA approved is shown right above their name. Cisplatin is the first, and like I said, it's just cis dichloro, right? There's 2 chlorines, diamino, 2 amine groups, platinum. So cis dichlorodiaminoplatinum or cisplatin. Carboplatin came out 11 years later. You can still see it has the amine groups, but now it has this kind of caged carbon structure, and that we'll talk about this, but that kind of makes it a little more stable, a little more carbony, so a little more lipid soluble. And then later, oxaliplatin in 2002, 13 years later. Again, now we kind of cage those amine groups. Again, another agent that has, these same electrophilic leaving groups, and then kind of a cage structure for the platinum, which makes it distribute a little bit different and have a little bit different pharmacology. But the core platinum in the middle and hooked to those amines, those amine groups are the structure that predominates. And there's a few other drugs that aren't worldwide use, and they're that are approved in Asia. Here's netaplatin, which was approved in 1995 and is used in Japan. Loboplatin, 2010, which is a molecule used for cancer treatment in China, and then heptaplatin is a drug that's approved in South Korea. So again, very similar structures, and I'm going to show at the end, that these drugs are still being developed, and that there's still platinum compounds that are being developed and being thought about, and trying to optimize their use. Now, in terms of how they all work, and this is more or less in the structure, I'm going to kind of talk about cisplatin, but you can see the structures up here are kind of conducive to both carbo and to some of all the other platinums. For cisplatin specifically, you get hydrolysis reactions that with chloride, and you get alkoxide or carboxylate anions acting as leaving groups, and you form this hydrated or aquated form of cisplatin or carboplatin or oxaliplatin. And that's critical because those are more reactive. Okay, that kind of activates those sites with those leaving groups, and they react with nucleophiles like DNA and with proteins at a much greater rate. Now, for cisplatin, this happens inside the cell, and the reason is because outside the cell, well, it can happen. It can happen outside cells. It can happen in the blood, but it happens more frequently inside the cell because there's higher chloride concentrations outside the cell as opposed to inside the cell. So to get that chloride to leave, if you have lower concentrations, you can push that kind of law of mass action, or that reaction, further to the chlorine leaving than you would with a higher chloride concentration like you'd find outside the cell. Then what are these going to do? They're going to get into the nucleus, and these aquated species are going to be highly electrophilic and will react with multiple molecules, including proteins, and the one we think about in terms of being a lethal lesion, they cross-link DNA. So you got two spots where these OH2s are, where you can react with platinum. So you can get both a inter and intra type lesion. So you can get it both across as well as within those DNA strands. Okay, so what are the determinants that cause tumor cells to be killed by cisplatin? One is uptake; they got to get in. Then there's detoxification reactions that can occur. Then DNA repair once they bind to DNA. Damage signaling: how does the cell respond to that damage? And then apoptosis. So you can get apoptosis triggered, or is it going to go not happen? So this sequelae of events is what I'm going to talk about next, in terms of to try to kind of explain why certain genes and why certain upregulation or downregulations can affect the activity of cisplatin. And we're going to start by talking about uptake. Now, in terms of cellular transport, there's CTR1 and CTR2. Those are the copper transporter proteins, and it's interesting because cisplatin, is a transition metal like copper, like zinc, and it turns. I teach heavy metal toxicology, so all these things react with proteins and redox cycle, and platinum can do that as well, and they all react with thiols, and so you have a lot of the players in this are involved in heavy metal toxicology and heavy metal sequestration in the cell as well. But the point is that cisplatin and these other drugs get in through these copper transporters, or by organic cation transporters, or by VRAC, and they get pumped out by MRP, whether it be as a glutathione conjugate or independent, and some of these other copper transporters that can be sequestered. And the CTR1 CTR2 story is very interesting, because CTR1 and CTR2 they're next to each other, and it came about by a gene duplication, and CTR1 and CTR2 are very similar, except the CTR2 is missing some components to it and doesn't seem to function as a uptake transporter, but more as a sequestration, where it pumps it into vesicles and then get excreted. So CTR1 is an uptake, and CTR2 is a pump out mechanism. So there's a little bit of a complicated relationship between influx, efflux, and sequestration by a combination of proteins. ATP7B, right, it's kind of the same thing. It pumps it into these vesicles, and then those vesicles go and fuse with the membrane and kick copper out, and in this case platinum out, whereas ATP7A is more of a kind of a pump. Does this play? I mean, these both play a role. And here's a study that looks at copper transporter expression with platinum resistance, and this is in ovarian cancer. And what you see in patients is, if you just look at expression of CTR1 in the tumors, positive and negative, there's not really much of a change. But if you look at the CTR2 positive and negative, you can see that if you don't have CTR2, that you do much better. And if you look at CTR2 negative, CTR1 positive, then all of a sudden what you see is that you get a better response. So I'm sorry, if the ratio is positive, which means there's more CTR2 to CTR1, you're going to do worse, because it's going to pump it out. If the CTR2 to CTR1 ratio is below, right, or is below 1, the smaller it is, you get better response, because more CTR1 relative to CTR2 means better outcomes. Okay, so this pumping it in versus pumping it out or sequestering it with CTR1 and CTR2 seems to play a role, at least in this response to these epithelial ovarian cancer patients from this study. Okay, so the point here is that this transport in and out both play a role, and it's complicated, and it's not just one protein that pumps it in or pumps it out. And so you have to look at the whole sequelae, the whole kind of picture of expression, to get an idea of what's going on. Now, when we talk about detoxifying reactions, platinum reacts with glutathione, it reacts with cysteine, it reacts with methionine, it reacts with thiols. So, GSH, glutathione substrates, or adducts might be substrates for MRP. So you may, pump it out better. These glutathione dependent transporters, some of the ATP binding cassette transporters pump out, glutathione adducts better than they do free drugs. And glutathione can react with cisplatin either spontaneously in the cell or by, metabolically via glutathione S transferases. The other thing is that metallothionein, right, which has lots of thiols and can, is meant to bind proteins, or I'm sorry, meant to bind heavy metals to keep them away from killing everything, because of their toxicity. It also reacts with platinum, so you can sequester platinum in metallothionein, and the role, and it gets more complicated because excess zinc can induce metallothionein, which can also affect copper levels and potentially CTR1 levels. So if you induce, metallothionein with zinc supplements, or you have too much zinc, you may have too much metallothionein, and you might have a lot of cisplatin in the cell, but it's getting bound up. So there's some tricky interactions between other heavy metals and essential elements like zinc, right? You got to have it, but how much zinc, and does it make a difference in terms of response to these things? And certainly with cells in tissue culture, if you add zinc and copper, you can alter the response of these cells to cisplatin. Why? Because we're altering glutathione levels, we're altering metallothionein expression, you're altering CTR1 levels, right? Because if copper goes too low, the cell upregulates CTR1 to pump more copper into the cell. And so you get these complicated relationships between these heavy metals in terms of these regulatory proteins that are meant to, to keep them at a level where the cell can still live, but not so much that they're causing damage. And so you have this trade-off, and platinum sequestration and movement can kind of fit right in the middle of that. So the story is not crystal clear in terms of some of these detoxifying reactions, and there's a lot of other players that can influence the milieu that the platinum drug finds itself in. Okay. The other thing is, once it binds to DNA, there's lots of DNA repair proteins. We think that nucleotide excision repair plays the most prominent role, where it just comes in, it recognizes, and you get you get it unwound, and you cut out that damaged area, and then you have another polymerase come in and fill it in. So you have recognition of the damage. You have a recruitment of all the repair processes. You get cleavage fixed, and then you make the new DNA. So homologous, nucleotide excision repair and ERCC2 certainly play a huge role, or ERCC1, one of those, play a huge role in fixing platinum-based damage. But there's also XPC, overexpression. There's lots of publications up here. These other factors, XPC overexpression increases cisplatin resistance, UV-DDB. So these damage recognition proteins that are associated with the excision repair complex can affect things. Helicases, you got to unwind it to fix it. Scaffolding proteins, some of the exonucleases, NER initiation and ligase proteins that put things back together. So all of the proteins in these complexes seem to play a role, as well as homologous recombination, non-homologous end joining, translesion synthesis. There are other, DNA repair pathways and DNA damage tolerance that play a role in determining the response. So, there's lots of moving parts to fixing these lesions, and it's not just one protein that plays a role in excision repair. You got to have recognition. You got to have, you got to cut it out, like the diagram shows. You got to unwind it. You got to cut it out. You got to put it back in. You got to ligate it back together. So all of these players can play a role in terms of sensitivity and or resistance. So what about that? Here's ERCC. Here's a correlation of ERCC1 gene expression and measures of cellular response to cisplatin-induced death. So this is the surviving fraction in cells, and you can see that you get a correlation. The surviving fraction goes up as ERCC1 expression goes down, and the IC90 goes up with increased ERCC1 expression. So the more DNA repair proteins you have, the less sensitive you are to cisplatin. Why? You can fix the damage. So this is done in cells. This is done in human cervical tumor cells, where you see that the more DNA repair you have, the less sensitive you are to cisplatin. Okay. So again, relatively straightforward. You make the damage, or it gets in the cell, makes damage. If you don't fix the damage, you die. If you do fix the damage, you don't die. Okay. But what does death look like? I mean, that's always an interesting question with tumor cells, right? So, you have damage sensing, you have, and you have this aquated form of this heavy metal. So you can get some redox and ER stress. They can cause mitochondrial DNA damage, not just nuclear DNA damage. What does that do to, signaling of various proteins, BAC1, VDAC1, right, which causes swelling of mitochondria. BACs, you have these pro-apoptotic and anti-apoptotic things going in, which are going to have, effects on MOMP, the mitochondrial, outer membrane potential that plays a role in senescence and or, cell death. P53, does it decide to, signal for apoptosis, or does it, tell the cell to senesce? What does the DNA damage do? Does that go through P53 and through apoptosis? So the point here is that, there's a lot of moving parts in terms of inducing apoptosis and how the cell responds to this damage. If it senesces and then has more time to fix the DNA versus says, screw it, I'm just going to die. That's those signaling pathways in terms of damage response also play a role. So it's not just, can it fix the DNA? Does it have time? And are these other apoptotic or anti-apoptotic responses more favored? And so all of those things play a role, from getting in the cell, right? It's got to get in the cell. Is it detoxified or is it not? Is it sequestered? Or is it pumped out? Once it gets in, does it cause DNA damage? Do you have increased DNA repair that fixes that? Do you have increased tolerance that puts them in senescence? or do you actually, induce apoptosis or not induce apoptosis? So all of these things are critical for any drug almost, right? All drugs, you have these very similar things, but for the platinum agents, we've studied these a lot, and we know how they get in. They don't just cross the membrane, by just gliding across. You have these uptake pathways associated with copper transporters. You have detoxification that's also associated with heavy metals, with metallothionein or other nucleophilic scavengers, and things like glutathione. And then once you cause DNA damage, can you repair it? Or is that damage signaling happen fast, so the cell goes, screw, we've been damaged, we're going to die? Or do they senesce and then fix it, and you don't go through apoptosis? So all of these processes play a role in determining your response to these drugs. And the reason I bring this up is a lot of the things that we're trying to do is to try to work out, right, what dictates whether a tumor is going to respond to a drug. And it's not simple. It's not just one thing. And so you need this kind of my selling, that we need good data about DNA repair and how these things interact, pathway modeling, and all those things to really get an idea at the granular level what causes a tumor cell to respond in a positive or negative way to chemotherapy. All right, so I think that's all very important. All right, what about the toxicity of platinum agents? They can cause ototoxicity, cardiotoxicity, nephrotoxicity. You can see myelosuppression, GI, hepatotoxicity, and neurotoxicity. In general, when we talk about dose-limiting toxicities, for cisplatin, it's renal, it's nephrotoxicity. For carbo, it's bone marrow suppression or myelosuppression. And for oxali, it's neurotoxicity. You get this kind of peripheral neurotox. Other side effects you see, right? Anaphylaxis, cytopenias, hepatotoxicity, ototoxicity, some of the other things that we normally see. And, from the veterinary side, there's an old saying, cisplat splats cats. And you get this severe pulmonary toxicity when you give cisplatin into cats. And so it's contraindicated in cats. So just another interesting thing that pops out when you're trying to do veterinary medicine with feline species. They don't react the way other species necessarily do to some of these drugs. So cisplatin is contraindicated. What's interesting is that the nephrotoxicity of cisplatin was actually recognized really early. Some of the early studies, this is a Nature paper from 1971, looking in some rats that had leukemias, and what they noticed was that it was nephrotoxic right then. And you can see some pictures here of the proximal convoluted tubules in rats after 5 days of treatments with 2 mg per kg of cisplatin. And it's really interesting because, why is cisplatin nephrotoxic, whereas carbo and oxali really don't cause significant renal issues? And this has been, kind of studied and thought about. One is the reactivity of cisplatin with proteins, and its formation of more kind of reactive aquated forms. And I'm going to show this in a slide, in a couple slides, that cisplatin reacts much quicker to plasma proteins. Reacting with plasma proteins means it's also going to react with proteins in the kidney. So when it's in the blood and it gets circulated, the fact that it reacts, if it gets picked up in the glomerulus, if it gets filtered, which it will, its reactivity means it's very well it's going to react with proteins in the kidney and cause the type of damage that's observed here, this degeneration and necrosis of epithelial cells. And so the kinetics of its ability to form and react with proteins is probably why, right? Because it's in the blood, it's cycling. Where is it going to go? It's going to go to the frickin' kidneys. The liver has a fair amount of regenerative capacity, as well as the fact that it has lots of glutathione. So a lot of it'll go to the liver, but the liver doesn't care so much. When it goes to the kidney, it's going to get filtered and concentrated in the kidney, and you're going to react with the proteins there. So it's probably just the rate of this reaction. In terms of nephrotoxicity, generally patients are prehydrated with saline. You get prophylactic treatment with mannitol to enhance urinary flow, and very often you're going to give a loop diuretic, a high volume diuretic like furosemide as well, to keep urinary flow, dilute out as much as you can that filtered cisplatin to limit the reactivity. So dilution is a solution to pollution. And in this case, keeping the cisplat that is filtered more dilute and keeping urinary flow going will help limit that damage. And so just something to think about, and why cis is different than carbo, different than oxali, that don't, carbo and oxali really don't show this renal toxin. That's probably why it occurs that way. Now, when we talk about the platinum pharmacokinetics, it's always important to note that there's a difference between the total platinum and the ultrafiltrate. And the reason this is because when we measure these drugs, we generally don't measure the drug itself. And what I mean by that is we don't really measure the totality of the drug. We usually do a kind of just analysis for platinum, right? So you do an elemental analysis for platinum, which is done by using something called ICP-MS, or inductively coupled plasma MS, which fries and strips everything else off, and you just get down to the element, which is platinum, right? And platinum, we can see on an MS, we know what its molecular weight is. So you just quantify platinum using this ICP-MS, or they used to use ICP-AA, atomic absorption spectroscopy, with the same ICP front end, but now we generally use MS. And so the problem is when you do that, right, if it's bound to protein and you have serum, it's still going to show up as platinum, even if it's bound to protein and inactive. So we actually measure what we call total platinum and ultrafiltrate platinum, and that's shown here. Here's in a patient. You can see that the ultrafiltrate platinum goes down very quickly. And by ultrafiltrate, we mean, we put it in and we filter out anything that's stuck to a protein, can't get through this semi-permeable membrane, and we're only measuring the free drug that's not protein bound. That doesn't mean it's cis-chlorodiaminoplatinum. It can be an equated form, but it's not bound to a protein yet. It's not bound to something big enough to keep it from coming into this filtered. So, because of the nature of how we measure the drug and the fact that we measure total platinum, that you need to kind of sometimes think about doing this total versus free measure, and we do that by doing ultrafiltrate. And this free concentration is usually the best kind of measure of drug activity, because it's still the active drug. Now, when you talk about, and I kind of gave this one away a minute ago, when you talk about platinum binding to proteins, here's a paper that looks at the binding rate, and CDDP is cis-dichlorodiaminoplatinum. LOHP, this is actually oxaliplatin, and this is carboplatin. What becomes, if you look at the scale here, right, 30 hours, 50, we got twice as many hours here. Cisplatin by far reacts fastest. I mean, by 25 hours, almost all of it is bound to plasma proteins. And you can see within 5 hours, you got about 60%, so pretty quickly, this stuff starts to bind to proteins when you put it in serum or plasma. Carbo doesn't, right? That's why carbo's not, you don't get the renal toxicity. It doesn't, spontaneously muck up all the proteins. It takes a little different, a little slower for it to hydrate and aquate and become active. And that's probably facilitated in the cell. Oxali as well, much slower, right? This is 50 hours, not 30 hours. And, by 10 hours, it's still only about 50%, where 10 hours for cisplatin, it's almost 90. So you just have this slower rate, right, of breakdown, of spontaneous breakdown. This isn't metabolism. This is just spontaneous breakdown and binding to albumin in solution. So it just does it spontaneously. When you look at the plasma pharmacokinetics, right, you get this kind of rapid decay, which is between 14 to 50 minutes for cisplatin, 12 minutes to 100 for carbo, about 26 minutes for oxali when you're looking at total. The other thing to look at is the ultrafiltrate. The ultrafiltrate for carbo, it's about the same because it doesn't bind that fast. It's a little bit shorter for cis because it does. But then, so you have this rapid decrease that's in minutes, and then you have these other longer half-lives, which are in hours. You can see, again, the ultrafiltrate for carbo sticks around for a while in terms of this longer. For cis, it's shorter, so it doesn't hang out as long. The total sticks out longer. Why? Because we're not, once it binds protein, we don't filter those proteins. And then if you look at oxali, it's even longer. It doesn't have this kind of middle. It has a kind of a rapid and then a later time frame. Now we're talking hours, so you get this slower decay of oxali over hours in the ultrafiltrate, form, sticks there for a while. So again, this is very reflective of this. But when you look at the half-lives and how long this stuff sticks around, cisplatin, fairly short-lived, goes into cells, goes into the kidney, damages it. Carbo hangs out a little bit longer, goes into cells, does this stuff. Oxali, sticks around a little longer. And this again, what that means in terms of, does it go deeper? Is it this accumulation in these other tissues that lead to neurotoxicity? I mean, that's probably why. But it all kind of fits when you look at the distribution and pharmacokinetics of these drugs. Okay. All right. The other well-known thing with at least carbo, and this is one of the most used population pharmacokinetic things we have, and this is pop PK, because we're using a parameter that's patient specific, which is glomerular filtration rate, to figure out their dose. So it turns out, the low reactivity of carboplatin means you get this really clear correlation of carboplatin drug exposure with glomerular filtration. Why? Because it's all eliminated in the urine. And this was recognized relatively early by Calvert. This is called the Calvert equation. And it just says that the dose you give is equal to some targeted area under the curve you want times the glomerular filtration rate of the patient in mils per minute plus 25. And so basically, this is just showing the dose you'd give versus GFR for an AUC of 5, 6, or 7. And you can see for 5, it goes to, about 250 to a little over 400. I'm sorry, about 300 to 400. For 7, it's 400 up, almost to 750. But the point here is that you don't dose carbo in mgs, you dose it based on your AUC, what target you want. And we know, I'll show you in a minute, when we get to PK/PD, an AUC between 5 and 7 usually gives your maximal therapeutic response. So you actually, are dosing based on some physiologic function of the patient, which is awesome, because this, takes variability out, which is how Calvert and his sidekicks figured this out. So this patient, selective, this is personalized medicine, and I think it's really interesting because we talk about personalized medicine with regards to the genetics of the tumor, the mutations of the tumor, what we hit them with. In this case, that's not what we're going. What we're talking about is exposure. And so this is a physiologic parameter associated with the patient to give optimal exposure. So this is the PK side of that, personalized medicine component, which, is kind of largely ignored, although this is the oldest example of where we do this in cancer patients. Now, it may be something you can start if we work this out for other drugs, imatinib or whatever, and we can optimize those doses as well. You might be able to tear a little more variability off the response rate. But I do think it's important to point out that this is personalized medicine just done at the PK level. Okay. For my veterinary colleagues, this same relationship holds in cats. This is a good publication because it's one done by our esteemed leader here at the Flint Animal Cancer Center, Dr. Rod Page, and Dennis Bailey, I think, was a resident in North Carolina State when he did this, but Rod can correct me if I'm wrong. And you basically get the same relationship in cats, that for carbo, and remember, cisplat splats cats, carbo doesn't. It doesn't cause that lung damage. And you can dose cats by glomerular filtration as well. It's a little bit different. It's body weight and GFR instead of just GFR in this random addition. That may be because maybe cat weights are a little more varied than what we see in humans. I'm not sure about that. I haven't looked into that, but there's just, again, the basic physiology from a human to a cat does the same thing. I'm sure it holds in dogs. Dogs are more dosed at a more fixed rate. I think it's 450 mg per meter squared with carbo, or 550 in that range. But, it's something that I was looking yesterday to try to figure out. I go, this had to have been done in dogs. And that really, I'm sure somebody's looked at it and it probably works, but they just haven't put it into process yet. Because it seems to me that there's no reason the physiology in a dog wouldn't give you the same type of relationship, but we don't dose dogs this way with carbo currently. But anyway, the Kitty Calvert equation as derived by Dr. Page and colleagues. Okay, so what about the clinical use of these drugs? For human oncology, cisplatin, the FDA approvals, testicular, lung in combination with Gemzar, bladder, cervical in combination with Gemzar, and for ovarian. For carbo, ovarian, lung, carbotaxol for lung, carbotaxol for head and neck, carbotaxol for endometrial, carbotaxol for cervical. So those are all kind of with paclitaxel. And oxali, I mean, Folfox, right, for colon cancer. So we know this is for colorectal tumors. For stage 3 colon cancer, oxali is part of that Folfox regimen. If you go on to clinicaltrials.gov and you look, these drugs are still being actively studied for other indications with other combinations, certainly with immunotherapies and with other targeted agents. And so, there very well could be other, both primary treatments as well as salvage therapies that come around that involve platinum agents, because these are still, pretty effective drugs. So, they're still pretty well studied, all right, and still being clinically studied for utilization. What about in veterinary onc? Like I said, cisplat is contraindicated in cats. Nephrotoxicity in dogs limits its use. It is used in canine osteosarcoma a little bit. And there's intralesional use in sarcoids and squamous cell carcinomas in horses. I had to put the cat and dog picture. I have a corgi. He's bigger than our cat now. We also have a gray tabby, and she slaps him all the time. But he's bigger than her now, so he'll roll her, and they'll roll around on the ground and fight. But if you got a corgi and a cat, you got to put the picture up. So anyway, for carbo, it's preferred over cis due to reduced nausea, vomiting, and nephrotox. Myelosuppression is dose limiting. Canine osteosarcoma as well as other sarcomas and carcinomas. Carbo has been used in the veterinary space, and for feline cancers, head and neck adenocarcinomas, mammary carcinomas, vaccine-associated sarcomas. These drugs are pretty deep in terms of use in veterinary medicine. Why? Because they're pretty safe, and they do seem to have some efficacy. Carbo and dox are used a lot in osteosarcoma. Carbo's first-line treatment is a single agent for osteosarcoma. So, these drugs are used in veterinary oncology a fair amount. Okay. All right. So what I talk to next is there's such good pharmacokinetic, pharmacodynamic data with platinum drugs that we have to talk about it. And here's a study that came from Merrill Lagorin when he was at University of Maryland. Merrill was a very well-known cancer pharmacologist, one of the leading kind of he's an oncologist as well. He died of multiple myeloma about 10 years ago now, but kind of one of the major players in cancer pharmacology for a very long time. Dr. Gorn, worked out this, and his colleagues worked out this kind of springboard off of the Calvert equation, where let's take creatinine clearance, body surface area, and pre-treatment platelet count and desired platelet count and work out a dose. And so what they were doing basically is modifying the dosage based on creatinine clearance and body surface area by your desired treatment nadir, right? I mean, your desired platelet nadir. So how far down can we take the myelosuppressive effects? With the clear relationship between creatinine clearance and dose, they were able to do this just based on, instead of having AUC over here, because AUC is going to correlate to these effects with pre-treatment platelet count and your desired nadir, they're able to just kind of substitute this in and work out doses. And you can see they could do it both in pre-treated and untreated patients. They had to kind of subtract a little bit from the dosing here effectively for pre-treated patients, because they're a little more sensitive to the myelosuppressive effects. But when you look at the observed versus what you predicted, man, they could do a really nice job with these doses in this patient population of saying, hey, we're going to dose to this nadir. So, the reason you can do that is because the AUC correlates to the nadir, and there's clearly a relationship between AUC exposure and myelosuppressive effects. And then you can do AUC targeting via use of creatinine clearance. And so you get this kind of nice link between your pharmacodynamic endpoint, which is a toxicity endpoint here, right? We're not talking about efficacy. We're talking about myelosuppressive effects, but still a pharmacodynamic endpoint of desired a targeted myelosuppressive, how far are you going to take them down, and you can work out your dose from there. So that's pretty slick that this has been worked out for these drugs, and now it's kind of baked into the AUCs, so it's not done so much anymore because you just use AUCs that target that. But around this same time, there was some other work that came out that Dr. Gorn was also involved in, although he wasn't the primary pusher of this. And this is pretty cool because what this actually did was looked at tumor response, and they also did toxicity. So here's likelihood of toxicity, and you can see that there's both pretreated and untreated patients here, but you can see that it goes up, okay, and then it just really takes off, above basically 7 and 8. Whereas at some point, you have 100% of your patients at certain AUCs seeing, toxicity, which at this point is, greater than or equal to grade 3 thrombocytopenia, which is on the top, or leukopenia on the bottom. And so you get this toxicity that really springs above, kind of an AUC of 7 or 8. And when they looked at the probability of response in these patients, and there's both complete response is the circles, and then complete response plus partial response is the squares. So you can see that's higher. What you can see here is when they actually fit this and modeled it, you don't really see a large increase in your responses. It kind of flattens out once you get above an AUC of 7. And this is really, really interesting, right? Because what this tells you is that your toxicity shoots up, but your efficacy doesn't shoot up. So there's no reason to push the doses above 5 to 7 in terms of your AUC for these drugs. And so, I think, when we've done studies with carbo, we've done PK studies, the targeted PK is usually 6 or 7. And it makes sense, right? Because that's where you're seeing efficacy without toxicity, and you don't get any more bang for your buck per se by pushing patients to a more toxic dose. So, this is kind of one of the nicest examples of how we wound up with a dose that seems to give us efficacy with acceptable toxicity. And in this case, there seemed to be data to support that, instead of it being a little bit more serendipitous or a little bit more guessy. This is fit. And again, the clear dose exposure relationships allow us to put this in the AUC realm once we get to the creatinine clearance as a use variable for dosing. Another example, and this comes from pediatric medicine, and what they're doing here is they're testing 3 different dosing protocols. One's a 6-hour infusion, one is 3 daily 1-hour infusions given over 72 hours, and then one's just a straight 72-hour infusion. And what's shown here is the free platinum levels, and as you could guess, it goes up and then it comes back down, right? And then if you give a 1-hour infusion, it goes up a little bit higher. And then if you give a 72-hour infusion, your rate is much lower, and you get lower levels. When you looked at the platinum max, so the maximum concentration based on the delivery rate, you can see it went up. So the maximum platinum concentration was a function in a series of patients of delivery rate, which makes sense, which would argue in your 3 by 1 hour infusions where you're having the highest delivery rate, you're going to have the highest peaks. And that's kind of shown here in this one representative patient. But when you look across a patient population, that was clear, and you get this kind of linear relationship. The faster you give the drug, the more your maximum concentration is. But the area under the curve, so the total exposure, so if you turn all these guys on their side to match that, the area under the curve with the slower deliveries were all the same. Okay, so our max went up to be higher, but our AUC was exactly the same. And if you look at glomerular filtration rate and the decrease in these patients, as well as looking at it later in a follow-up up to a year out where it was still decreased, the nephrotoxicity in these pediatric patients correlated with the maximum concentration both in the plasma and the urine. All right, so this fits with our model of what we're talking about in terms of cisplatin nephrotoxicity, in terms of it being filtered and causing damage. But what this tells us is that if we minimize the maximum platinum concentration, we minimize the decrease in renal function, which argues that if you give it by a 72-hour infusion or longer infusions, you can get equivalent exposure slash efficacy and less toxicity. And I think this is a really good example how just changing how we deliver the drug can alter the toxicity profile while probably not having a major effect on outcome, because our outcome here is all based on AUC, okay? And so again, total exposure here seems to play more of a role than max, and longer infusions in these pediatric patients may spare the kidneys, okay? Decrease nephrotoxicity by decreasing the Cmax levels of your free platinum. How do you do this? You give it at a lower rate, slower rate. Okay. So again, I think a really nice, clear example of PK-PD relationship with our platinum drugs, and in this case, our PD relationships, again, a toxic endpoint, but one that we're going to try to limit and optimize our efficacy. All right. My last two slides are going to kind of talk about the future of platinum anti-cancer agents. And a lot of this comes out of a review article from 2016. So not too old. It's only 6 years old, not 10 years old. And, you know, there's lots of new drugs coming up. Some sterically hindered platinum compounds. And the reason they want them to be sterically hindered is they think that if these chlorines leave and they become aquated, that if you make it bigger, it can't get into proteins and damage the proteins. So they're trying to get these sterically hindered compounds to cause less reactivity and damage to plasma proteins and you know, proteins in the kidney. Platinum 2 complexes with biologically active ligands, and in this case, you know, we're looking at estrogen, right? So you can now target at the breast cancer by putting an estrogen there and delivering your platinum drug that way. Monofunctional platinum complexes, that means it only has one chlorine leaving group, which is shown here with phenethylplatin. The idea with these is that you have this kind of planar intercalating agent. So it's thought that the bifunctional alkylation to be able to bind twice off the platinum, right? Both two chlorines, you can have two binding spots. Means that those lesions are harder to fix. That's true. We know that you need to go through the whole kind of clear it out, because it's not just one. It's not base excision repair. You need nucleotide. You need multiple nucleotide excision repair, which is a more difficult process for the cell to monitor and take care of. But they think that these single alkylation events with an intercalating agent will stick this in the DNA enough that it's going to also cause these kind of bulgy problems with the DNA, such that you're going to inhibit replication, inhibit transcription, and do the things you need to do to muck up the tumor cell. So some of these monofunctional platinum complexes are being studied. These platinum complexes with a trans instead of a cis geometry. This one gets a little bit weird too, because historically they've thought that cis geometry is critical for these inter and intrastrand crosslinks. There's some idea that maybe these trans platins might work, but they're going to react slower. I don't know if that's good or that's bad. This is the one I'm like, I'm not sure about that. Polynuclear platinum complexes. Now we got lots. We got 2 platinums here now, so we can bind the DNA all over the place. Now we can bind to 4, so you got DNA stuck all together all over the place, so you can cause more damage. And then these platinum 4 prodrugs with bioactive ligands. Here's an estradiol conjugate. Here's, you know, one with none, which is satraplatin, which is an orally bioavailable platinum agent, which has undergone, you know, it's gone to phase 3, I think, in humans where it failed. It's been tried in dogs as well for exposure with Shanaclon at Maryland. And then there's some photoactivatable platinum complexes where, you know, now we're bringing a photodynamic type component to it. You know, can you put it in the tumor and then shine a laser and get the platinum to be more reactive now? So a lot of different strategies to utilize the basic platform of this electrophile that can, you know, that can bind to DNA, right? But, you know, it can go find and bind to DNA and muck it up. Okay. So anyway, these are the ones that are potentially, some of these have already been in the clinic and have failed. Some of them are still coming down the pike, but I think it's important to note, especially for people in developmental therapeutics. There's people are still making platinum drugs and thinking about platinum drugs. There's also delivery mechanisms. There's also pro-drug things people are doing. Lots of different things that people are looking at with regards to these drugs. All right, I'm going to end by talking about markers of response and further therapeutic analysis. And here's a paper from Nature Communications a couple years ago that starts looking at mutation status, and you can see that BRCA mutants had a much higher a significantly higher fraction of patients that responded as opposed to BRCA2 wild types. That you didn't see that with ERCC2 mutants versus ERCC2 wild types. So BRCA seemed to play more of a role in response. And this paper looked at a lot of molecular correlates for this kind of multi-omics analysis. I didn't want to go into that because I don't think that's really what I wanted to get to here. But I think that, genomics to get the right drug in the right patient. And then with these things, based on GFR, we can do it at the right dose. So we got the triumvirate: right drug, right patient, right dose for their tumor. And this brings up the concept of targeted cytotoxic chemotherapy. And clearly this is something I've been working on for a while with Coxon, our involvement in some of the Coxon stuff that was done. And, we've certainly had gene expression models to predict carbo and cis sensitivity and in MVAC and in GC and in bladder cancer, so GEM-cis and MVAC. And we also did this in dogs for the Coxon trial we did in dogs with carboplatin and doxorubicin. We had a carbo gene expression model. So gene expression, drug response, mutational spectrum, how do all these play in to getting the right drug into the right patient? And my point here is it's maybe not just a caveat for targeted agents where we think about mutation, the whole basket trial idea where we look at, tumor mutations and then, pull the kinase inhibitor that it targets off the shelf. This is also a concept that, and certainly, Dan Theodorescu has been thinking about this for a while with bladder cancer, and other people have too, but, gene expression and other things in that tumor that might dictate that a platinum agent, might be the best one. And then you target it further, right? A platinum agent, this patient has a little bit of renal insufficiency. Let's not go with cis, let's go with carbo. Make sure that they're both the same. Right patient, right drug, right patient, right dose. And I think, that's where we all want to go. So anyway, that's my kind of spin on platinum agents and targeted cytotoxic chemotherapy to run this off at the end. So when we talk about targeted therapy, it's not just tyrosine kinase. The next one of these schedules is April 14th. I'm looking for other participants to lecture in this series. I'm going to try to get some other people. And if not, I'll pull up a topic to talk about. But with that, if there's anybody that's watching live, I will certainly take any questions.